There is a pill sitting in a medicine cabinet right now. Maybe yours, maybe your parents'. A small white tablet taken every morning without question. Trusted because a doctor prescribed it. Trusted because it has been taken for years. Trusted because the number on the blood pressure cuff looks fine at every appointment. And that trust may be costing someone their energy, their metabolism, their mobility, and in some cases, years of life. This is not a story about bad doctors. This is a story about old science that never got updated, about prescriptions written in one decade that are still being quietly renewed in another, about 3 of the most commonly prescribed blood pressure medications on Earth that research has since shown may cause serious harm in the very people they were meant to protect. Meet Lester, 73 years old, retired postal carrier from Dayton, Ohio. For 31 years, Lester walked 12 miles a day delivering mail in every kind of weather. His neighbors set their clocks by him. When he retired, the habit stayed. 3 miles before breakfast, rain or shine. He was not a gym person. He was just a man who had always moved, and moving made him feel like himself. Then his doctor prescribed a blood pressure pill called atenolol. Within a year, the walk stopped. Lester told his wife he just did not feel like going out anymore. He sat in the recliner most of the day, exhausted by mid-morning, asleep by 8 at night. His wife thought he was depressed. His daughter thought he was giving up. His doctor looked at the chart and said everything was fine because the blood pressure at the 1 o'clock appointment looked perfect. Nobody connected the recliner to the pill. Nobody asked the question that needed to be asked. Atenolol has been prescribed since 1981. Cardiologists who study it closely have a private name for it. They call it the placebo with side effects. That phrase was born from a devastating 2004 study by Dr. Bo Karlberg at Umeå University in Sweden, where his team analyzed outcomes across more than 24,000 patients in every major atenolol trial. They were not looking at blood pressure readings. They were looking at who lived and who did not. When atenolol was compared directly against a sugar pill, it reduced cardiovascular mortality by exactly 0%. It did not prevent a single heart attack. It did not extend life by a single day. The only things it reliably produced were chronic fatigue, rising blood sugar, and bedroom problems nobody mentioned at the appointment. The reason it fails goes deeper than the number on the cuff. When your heart pumps, it sends a pressure wave down the aorta, the main pipe leaving the heart, like a shock wave through a tunnel. That wave travels to where the arteries branch, bounces back, and normally returns to the heart during the resting phase, the moment when the coronary arteries that feed the heart muscle itself are most open to receive blood. Atenolol slows the heart so dramatically that the timing shifts. The reflected wave arrives too early, crashing back into the aorta while the heart is still actively pushing blood forward. 2 forces colliding head-on inside the pipe. The blood pressure cuff on your arm cannot detect this collision. Your doctor sees a perfect reading. Inside your chest, the vessels feeding your brain absorb the impact of that collision with every single heartbeat. The LIFE trial in 2002 confirmed the consequences in more than 9,000 seniors. Despite nearly identical arm pressure readings, losartan reduced strokes by 25% compared to atenolol and reduced new-onset diabetes by 25%. Same arm numbers, dramatically different outcomes, because the arm number was never the number that mattered. And about that diabetes, this is the part Lester's doctor never explained. Atenolol blocks the beta-2 receptors on the surface of the pancreatic cells that produce insulin. When those receptors are blocked, the calcium channels inside the cell cannot fully open. Without calcium, the tiny packets of insulin the cell has manufactured cannot fuse with the cell wall to be released into the bloodstream. The insulin is made. It is sitting inside the cell, but the delivery mechanism is frozen. Meanwhile, glucose piles up in the blood because the insulin is trapped inside the factory. Lester's fasting glucose climbed from 95 to 118 over 2 years. His doctor said he was pre-diabetic and told him to watch his carbs. Lester cut out bread, pasta, sweets. The number barely moved. He cut out fruit. Still 114. He was punishing himself for a number his pill was creating. The ERIC study confirmed a 28% increased risk of new-onset diabetes in seniors on atenolol. Not from eating too much sugar, from a blood pressure pill holding the insulin release mechanism hostage. If you are on atenolol and your blood sugar has been climbing while your diet keeps shrinking, this is what may be happening inside your pancreas right now. The second pill is hydrochlorothiazide, often called HCTZ. It has been prescribed since 1959 and remains one of the most widely used blood pressure medications on Earth. Your doctor may have chosen it because it is inexpensive, familiar, and reliably lowers the number on the cuff. What the appointment did not cover is what it quietly drains from your body along with the water. HCTZ works inside the kidney by blocking sodium reabsorption. The sodium stays in the urine, water follows, blood volume drops, and blood pressure drops. That part works as advertised, but the sodium that HCTZ forces downstream does not leave quietly. It floods the collecting duct, where the kidney panics and begins trading sodium for potassium to compensate. Your kidneys dump potassium into the urine day after day, month after month. A healthy level of 4.2 can fall to 3.4. Your doctor says borderline low. Maybe eat a banana. What 3.4 actually means is that the electrical reset system in your heart is already dragging. Every heartbeat has a precise electrical sequence. Sodium fires to contract the muscle. Then potassium opens channels to reset the charge so the heart can beat again. When potassium is low, that reset slows. The heart enters an electrical twilight, neither fully contracted nor fully relaxed. And in that vulnerable window, a rogue impulse from another part of the heart can trigger a chaotic rhythm called torsade de pointes. The heart quivers instead of pumping. Blood stops reaching the brain. An electrophysiologist would not call 3.4 borderline. They would call it a ticking clock. But HCTZ does something else that most patients are never told about. Research from the University of Southern Denmark using the Danish Cancer Registry found a 700% increased risk of squamous cell carcinoma after long-term use. The HCTZ molecule contains a chemical ring that acts as a photosensitizer inside the skin. When ultraviolet light strikes the HCTZ molecules embedded in skin cells, they shed electrons and generate swarms of free radicals that tear through DNA. A healthy body can repair occasional sun damage. Daily drug-amplified damage overwhelms the repair system. The mutations pile up. The cells forget how to stop dividing. 700% is not a number any senior should learn about from a YouTube video. It is a number their doctor should have explained the day the prescription was written. The third pill is amlodipine, brand name Norvasc, the most prescribed blood pressure medication in the world. It relaxes artery walls by blocking calcium channels in smooth muscle cells. Arteries open, pressure drops. That is the version that fits inside a 5-minute appointment. That version leaves out the most important part. Amlodipine relaxes the tiny arteries feeding into the capillary beds, but the tiny veins draining those same capillary beds do not have the same calcium channels the drug targets. They stay narrow. Now a fire hose volume of blood is pushing through a wide inlet into a narrow exit. The pressure inside the capillary skyrockets. Clear plasma fluid is squeezed through the capillary walls and pools in the tissue of the ankles and feet, pulling the skin until it is tight and shiny. This is not fluid retention from eating salt. This is a mechanical pressure failure inside the microvascular plumbing. At 10 milligrams, up to 30% of patients develop this edema. In women, the rate is even higher. Here is where it becomes a cascade. The doctor sees swollen ankles and adds a diuretic to drain the fluid. The diuretic depletes potassium and magnesium. The swelling returns because the pressure mismatch is still there. The diuretic dose goes up, the potassium drops lower, and now there are 2 pills on the counter. The second one treating a side effect of the first while creating new side effects of its own. And deeper inside the cardiovascular system, amlodipine triggers something more dangerous. When it forces the arteries open and blood pressure drops suddenly, pressure sensors in the neck detect the change and interpret it as a medical emergency. The brain fires the sympathetic nervous system, convinced the body is hemorrhaging. The kidneys activate their emergency fluid retention pathway and begin locking down sodium and water to expand blood volume. The heart is now forced to pump this artificially expanded ocean of fluid every minute of every day. Over months and years, the continuous strain stretches the left ventricle like an overused rubber band. The muscular wall thins, pumping power drops. The All-Hat trial found a 38% higher risk of heart failure with amlodipine compared to the alternative. A pill prescribed to protect the heart ends up drowning it in volume it was never designed to carry. Now consider what happens when a senior is on all 3 at the same time: atenolol, HCTZ, and amlodipine. This is not a hypothetical. Many seniors are. And when these 3 drugs operate simultaneously inside an aging body, they do not cooperate. They fight. Amlodipine forces arteries open and triggers the kidneys to retain sodium and water. HCTZ is simultaneously forcing those same kidneys to dump fluid. The pharmacological tug-of-war damages the delicate filtering units inside the kidneys while depleting the potassium the heart needs. When low potassium causes the heart to begin misfiring, the nervous system would normally release adrenaline to stabilize the rhythm, but atenolol has padlocked the receptors that adrenaline needs to reach. The rescue signal fires and bounces off. HCTZ is pushing the heart toward a cliff. Atenolol cuts the parachute, and the metabolic damage multiplies. HCTZ starves the pancreas of the potassium needed to begin insulin release. Atenolol simultaneously blocks the receptor needed to complete it. The pancreatic cell is under a double chemical siege. The risk of new-onset diabetes does not add these 2 effects together. It multiplies them. Lester was on all 3. His fasting glucose was 118. His potassium was 3.4. His ankles were swollen. His heart rate was stuck at 52. He could not walk to the mailbox without stopping. His doctor saw 128/82 at the appointment and said everything looks great. Everything was not great. It was Lester's daughter, a nurse practitioner, who changed everything at Thanksgiving dinner. She looked at his pill bottles and asked why he was on atenolol when the LIFE trial had proven losartan superior 20 years earlier. She called his doctor the following Monday. They agreed to taper the atenolol over 4 weeks and replace it with losartan. In week 1, the chemical restraint on Lester's heart was lifted. His resting heart rate rose from 52 to 67. Oxygenated blood reached his muscles for the first time in 2 years. The leg fatigue that had made the recliner feel like the only option began to lift. He stayed awake past 8 o'clock for the first time in months. In week 2, the receptors on his pancreatic cells were unblocked. The massive backlog of trapped insulin was finally released. By month 1, his fasting glucose dropped from 118 to 96. The prediabetes diagnosis disappeared. Not because he changed his diet. He had already tried that for 2 years. The chemical hostage situation inside his pancreas was over. By month 3, the walks were back, 3 miles before breakfast, rain or shine. His daughter said something that deserves to be heard by every senior on an outdated prescription. She said, "Dad was not getting old. Dad was getting medicated." and the medication was aging him faster than time ever could. The average time between a landmark study proving a drug is inferior and medical guidelines being updated to reflect it is 17 years, documented in the Journal of the Royal Society of Medicine. Atenolol was proven inferior in 2002. Some guidelines did not fully downgrade it until 2019. During that gap, tens of millions of prescriptions were written for a drug the science had already moved past. Your prescription does not have an expiration date. It renews automatically. The science moves forward, the prescription stays frozen, and every year it stays unchanged. The pill that was supposed to protect your heart continues quietly doing the opposite. You do not have to wait for the system to catch up. You can walk into your doctor's office with study names, specific blood test requests, and a calm, informed conversation. Ask for serum potassium and RBC magnesium if you are on HCTZ. Ask for fasting insulin alongside fasting glucose if you are on atenolol. If your glucose is high but your insulin is low, that is not diabetes. That is a trapped delivery system. Ask for plasma renin and serum aldosterone if you are on amlodipine and your ankles are swollen. These tests cost less than dinner at a restaurant, and they tell a story no blood pressure reading can. The question is not complicated. It is simply this: is this still the right pill for me? The answer might be yes. Some people genuinely need their beta blocker. Some need their diuretic. Some need their calcium channel blocker. But the answer cannot be yes unless someone asks. And if nobody has asked in the last year, the person who needs to walk in and ask it is you. Lester got his walks back. His wife stopped watching from the window. His daughter stopped whispering. Not because he got younger, because he got the right pill. If this sounds like your story, leave a comment below. Tell me which blood pressure pills you take, how long you have been on them, and when someone last checked your potassium. That information is not just for me. It is for the person who watches this video after you, the person who is looking for someone who feels exactly the way they feel, and who has not yet found the words to describe it. Your comment may be the thing that finally gives them those words. Like this video if it reached you. Subscribe because the next one continues exactly where this one ends, and send it to the person in your life who takes a handful of pills every morning, who is tired all the time, who blames getting old, and whose doctor keeps saying, "Everything looks great." Perfect on the chart does not mean perfect in the body, and the pill that was supposed to help might be the one that needs to change.